Trauma, Principles, and Upper Body Injuries, presented by Dr. Kevin Pei, Assistant Professor of Surgery, Yale School of Medicine. Please give a warm welcome to Dr. Pei.
Hello, good afternoon. I hope your week has been going well. This afternoon, I have the privilege of discussing trauma. And so it's like one of those big topics in general surgery where you try to spend the next 3 hours or so discussing both upper and lower body trauma. I'm well aware of the vast amount of expertise and experience in this room. So clearly these next two lectures are not trying to make us experts in trauma, but to really highlight the high yield, what would be high yield on a standardized examination as it pertains to trauma. I have no disclosures. Through the next hour and a half, we will discuss principles of trauma care and really just going to kind of go head to toe. And then the second module will be related to lower extremity. We'll start with traumatic brain injury, work our way down to neck and facial injuries, cervical spine injuries, thoracic injuries, and then talk a little bit about pulmonary contusions and rib fractures. So principles of trauma. Let's start with the case scenario. You all have your little clickers available. The question is this. This is a 40-year-old man who falls from 40-foot or 40-feet scaffold and is brought to your trauma bay as a high-level activation, whatever that might be, at your hospital. On arrival, the patient's vital signs are blood pressure 90/50, pulse of 120. Oxygen sats is at 94% and a GCS, glass glaucoma scale of 7. This patient is intubated for airway protection. Breath sounds are present bilaterally. The next step in management should be all right, so great. So the majority of you guys picked the extended focus assessment of sonography for trauma, or EFAST. And I completely understand the 16% who also chose E as in Edward for holding pressure on bleeding open for a femur fracture. And I hope through the next couple of modules that I will keep repeating this very, very important concept, which is competing interests and systematic way of going through your ATLS. The reason that EFAST is potentially a better answer than, say, E, Edward, for holding pressure, because you're both at this point, you're done with your airway, you're done with your breathing, and you're stuck on C for circulation. You can't move beyond C for circulation because you haven't found the source of the bleeding. And the meat of the matter is that it's likely, given this patient's mechanisms, that there's significant intra-abdominal bleeding, which would very much affect your next step. It's either to the operating room, right? The reason that E is not technically wrong is because in real life, as you know, you can just assign somebody and hold some pressure there while you are looking for other sources of bleeding. But the crux of this question is to recognize that the overwhelming reason for hypotension in this type of a mechanism for injury is going to be intra-abdominal bleeding until proven otherwise. So principles of trauma, everybody's gone through general surgery residency, so everybody's very familiar with ATLS, that it's designed to be a systematic, protocolized way to evaluate patients no matter what the mechanism, what your suspected injuries are, and what the patient's clinical status is. And so we do primary survey, adjuncts to primary survey, a secondary survey, which is nothing, just a fancy name for a physical examination, head-to-toe physical examination, and adjuncts to the secondary survey. And in everyday practice is very much as well as on the examination. The diagnosis is often not immediately available, but that's okay. You just have to prioritize and treat. And the priorities, as every single scenario comes about, is that you want to manage the life-threatening issues at each step before proceeding to the next item in survey. So we don't move on from A for airway to B for breathing until airway has been secured, even though there may be something quite obviously wrong in C for circulation, for example, like somebody who with an open femur fracture. Okay. And one of the tidbits, and I'll remind the audience one more time as you're taking standardized examinations, is one of the tidbits is, especially for this group and the maintenance group, the MOC group, is that you have so much practical experience, you have so much experience in your own practices that you tend to overthink the questions because you'll say, that's not what I would really do. And so you want to take a 30,000-foot view and just step back a little bit and say, what would we be expecting 99% of surgeons to be able to answer for this question, not nuance, because especially when we get to the different other specialties, whether it's burns or pediatric or whatever, there are specialists sitting in this audience who would say, that's not exactly what we would do. So don't overthink things. Any change of the status, clinical status of the patient requires that you reevaluate the patient. And that means really going back to the primary survey and going through ABCDs again. Much of what we do in trauma surgery, unfortunately, is about prevention of secondary injury because the primary injury has already been taken care of, and there's nothing I can do to turn back the hands of time and say, well, I can prevent that MVC from happening. So in our priorities in the patients, traumatic patients, to try to prevent secondary injury. And we'll get a little bit about a balanced resuscitation. Balanced resuscitations is actually coming up on standardized examinations, which is a fairly new concept, but one that the American College feels very important. That is an important concept. Those of you who trained at least 10 years ago would remember that we in general as surgeons are very aggressive with fluid. Over the last 10, 15 years, we know that we are far less aggressive now than we were 2 decades ago, and we're pushing the envelope even further in trauma patients in that we do not need to maintain some artificial blood pressure. We have now permissive hypotension as long as we think that the gross overall perfusion is maintained, because we are recognizing that there's untoward effects of over-resuscitation. If you remember back to your ventilation module, it's the very same concept for ARDS patients where we have permissive hypercapnia. All right, very familiar slide to everybody: airway, breathing, circulation, disability, and exposure. Once again, to remind you, we don't move on until every single one of these systems has been taken care of. All right, next question. Which induction agent for intubation is associated with adrenal insufficiency? Fantastic, etomidate. So just to point a couple of other things out, both things I'm about to say is quite controversial right now. There is now new evidence to suggest that etomidate may not actually cause adrenal insufficiency, or to the degree that it becomes clinically important. And why am I bringing that out? Because some of you probably know that literature very, very well, and you're sitting there on the exam going, well, actually etomidate doesn't cause adrenal insufficiency. But for the purposes of a standardized examination, this is still the classic answer. It's etomidate. The other thing I want to point out to you is choice C as in Charlie, ketamine, right? We classically associate contraindication to ketamine use in a traumatic brain injury patient, correct? If you have an increased intracranial pressure or the risk thereof, that we don't use ketamine. Again, there's literature suggesting that that is just myth, but for the purposes of a standardized examination, ketamine should not be used in patients who you suspect have intracranial hypertension or increased ICPs. All right. So let's start with A, airway for intubation. These are fairly standard indications for intubation. Somebody who's comatose, who basically cannot protect their airway, and somebody who has major facial fracture, so that if you were to get a scenario about a patient who has significant facial fracture, any adjunctive airway maneuvers are inappropriate, particularly those that involve sticking something in the nose, like a nasal trumpet or a nasal airway. For those patients, the next step in management should be oral tracheal intubation. The gold standard, another one favorite question, is a gold standard to confirm tube placement is not listening to the breath sounds. It's not listening for or watching chest rise or seeing condensation on the tube. It's actually end-tidal CO2. Well, here's the caveat. If your patient is coding or is in cardiac arrest and there is no perfusion, there is no end-tidal CO2. So just look at the prompt and make sure that the patient, in fact, is not a coding patient, because in which case end-tidal CO2 is not that is not necessarily a reflection of proper tube placement. End-tidal CO2, though, is correlated very well with outcomes or the appropriateness or the effectiveness of your CPR. Okay, we talked about the contraindications in nasal airways, particularly major facial fractures. And of course, we're all surgeons sitting here, so we're always prepared for a cricothyroidotomy. Okay, next question. Interosseous access is contraindicated in which of the following scenarios? That's fantastic. This is the best group ever for this question. Okay, that's fantastic. And so basically, the rule of thumb is this: you can put interosseous in anybody. The only real contraindication to placement of them is, and it's not for the reason that I initially thought for why patients can't have interosseous placement for extremity fractures. It's not because they have a fracture. It's only because I am not certain whether or not the medication I'm giving can actually be delivered, right? Especially if you're distal to the fracture in the extremity. Okay, so that's the only reason. It's not because, oh, I'm worried about how the orthopedic surgeons can't fix this fracture after I put an IO in. All right, it's okay in awake patients. It's okay in adult patients. Even previous vascular bypass is not a contraindication. And pretty much any drug you can think of that you wanted to give IV can be given intraosseous. Okay, the only problem is it's very difficult. Just like when we infuse medications down the ET tube, we don't know the availability or the concentration that's going to be delivered. That's a very questionable amount. All right. Hemorrhagic shock classes is not really it's not really important to remember necessarily the different classifications, but to remember that our bodies physiologically has a lot of reserve. And so when you see outward signs of the classic hypotension, tachycardia, you have significant hemorrhagic or volume loss. And in trauma, we're not really talking about like the patients who are septic. In trauma, it's always considered blood volume loss until proven otherwise. So we went to A, went to B, or let's talk about circulation a little bit. So management of circulatory collapse is trauma. That's what we do. And then everything else is sort of housekeeping afterwards, right? Once you've stabilized the patient, everything else is just critical care. Not just, it's critical care, right? So you're basically maintaining the patient and trying to prevent secondary injury. So what we do, the most important thing in the trauma bay is to stabilize the patient from a circulatory collapse standpoint, right? The next law, right, is a very familiar law to everybody, which is why we prefer in massive resuscitation efforts to use a large bore introducer sheath. You may call it a cordis, as opposed to a triple lumen catheter, right? Because the smaller the radius of your conduit, the greater the resistance. EFAS is the tool to go to, but I will also tell you that I know that the paradigm has been that very few people do DPLs, with a few exceptions of trauma centers around the country, but that there is a role for a DPL, especially because FAST examinations and ultrasound examinations in general are very technician dependent, right? So if you've not been validated, or your technician at your local hospital has not been validated to say that their FAST, when they say it's a negative, that they have 100% negative predictive value, then there's still a role for a DPL when the patient is crashing and you just don't know whether or not your FAST is reliable. And so if I were you and the scenario came up that the EFAS was initially negative and the patient continues to be hypotensive, and DPL is one of the options prior to going to exploratory laparotomy, I would consider using DPL to confirm whether or not it's truly intra-abdominal hemorrhage. Possible sites of exsanguination, it leads you to this slide, right? So external bleeding that we may not have seen at the scene at wherever the EMS picked the patient up. Clearly thoracic, abdominal, pelvic fractures, and major extremities, the thigh can carry liters of blood, right? I would assume, though, that if you have a liter of blood or 2 liters of blood in your thigh compartments, that there will be a discrepancy in the size of the thigh. But, you know, in somebody who's average size. But clearly, if you start off with big thighs, it may not be very readily obvious to us. Scalp lacerations is one of the huge blood loss, source of blood loss. And so if you see somebody with a scalp laceration, the first thing to do then is just to staple the scalp to try to minimize ongoing bleeding. This is always a difficult question, right? These are the non-responders. I'm giving them blood and they're not responding, and I don't know why they're still hypotensive. I've done my EFAS, I got my chest X-ray. There's no discrepancy in the size of the thighs. There's clearly no scalp hematoma. Why are they still hypotensive? So the really common things that you should be aware of in trauma is a tension physiology, right? So even though you thought you heard breath sounds bilaterally, I will tell you the last time I truly heard anything really clearly in the trauma bay was a long time ago. So EFAS is really, really good for pneumothorax. It doesn't cost anything. If you suspect that you may have missed a pneumothorax, I would very much encourage you to do the extended portion using your ultrasound. And frankly, if all else fails and you just still doubt whether or not there is a pneumothorax in a patient who is hemodynamically unstable, I would just assume that there's a tension physiology developing and put a chest tube in. Okay? Neurogenic shock is something else to think about. We talk about how there should be very little reason ever to put pressors or vasopressors like norepinephrine or epinephrine in a trauma patient, because we should, if they're bleeding, we should be stopping the bleeding and replacing the volume, right? Well, there is a class of patients in neurogenic shock patients who have lost their systemic vascular resistance as their primary problem, and this is usually associated with a high thoracic injury, so that there's loss of sympathetic drive. And so I said there's a rare occasion for us to use vasopressors in trauma. And then, of course, blunt cardiac injury. It's rare that we see penetrating cardiac injury, but blunt cardiac injury can be a source of hypotension. I do want to point out, though, that tension physiology is something that we all as surgeons can fix very quickly. I would never, ever bet money on a patient who's hypotensive in the trauma bay that they have neurogenic shock or cardiac injury. Those two are way on the bottom of my list, and I would just do anything possible to look for a source of bleeding, because unless the mechanism is so clear that the patient has a neurogenic injury or spinal cord injury rather, and a cardiac injury. So remember our patient earlier, the 40-year-old guy that fell 40 feet, right? That's a very high fall. Vitals are the same there. And this is what you see on the E extended fast examination. And so the question is, if you're shown this image, you have the same exact clinical scenario, what next? You don't have to click. It's not a response. It's not in the response system. But that's clearly hepatorenal fluid. Sorry, my mouse. Oh, here we go. Right? Liver, kidney, lots of fluid. Okay? This patient ends up in the operating room. Okay? This is an exploratory laparotomy. All right? And that's something that I think it's a great take-home message. On the surgery boards, as is the case in the APSA examination, anytime a patient in a trauma bay is hemodynamically unstable, you got to go, this is a surgical exam, I'm probably going to have to go to the operating room. Okay? Don't stop at adjunctive studies, because that's not the right answer. Okay? All right. So I don't know how many in the audience are facile with EFAST. EFAST sort of came out after I finished residency, and so it's a tool that if you're a trauma surgeon, you must be facile with. And so all of us have internally validated that we are actually getting the results that we're looking for, right? But basically, it's fast examination, which everybody's comfortable with, the 4 quadrants, and then we look to the lungs to see whether or not there's quote unquote lung sliding, right? Ultrasound picks up lung sliding as motion artifact. So this sort of haziness right here, that's what we want. This is called a seashore sign, right? Because this looks like this is the chest wall up here. Remember, your probe is up here at the top of the screen. And first, you're going to go through the chest wall, which of course doesn't move. And then down here represents your pleura and your lung. And so what this looks like is waves of fluid going into or waves in the ocean going onto the sand or to the beach. Versus over here, there is no motion. There's no motion detected. There is no pleural sliding. And why is there no pleural sliding? You all are very familiar with the fact that most of our organs have 2 layers of pleura, and the space between them should, in all cases, be only a potential space. So when the parietal and the visceral pleura separate, the ultrasound machine no longer picks up the sliding of the pleura past each other. And so on the ultrasound, it's as if it looks like it's just staring at the chest wall. So there's no motion. All right. So you got a patient who's the same exact vital signs, who's hypotensive, tachycardic, same mechanism. You have an EFAST that's positive, but somebody brings up this chest x-ray, and what does this chest x-ray look like? Well, it's got a wide mediastinum, right? Is there anything that we need to do before saying, let's take our patient to the operating room who's hypotensive, who has a positive FAST, but boy, that mediastinum is incredibly widened, right? What's next? Well, the answer is it doesn't matter, because you know that the widened mediastinum is not the reason why the patient's hypotensive. It's probably something that you may want to have to look into later. It's most likely statistically nothing that you're going to have to do, right? Because as you know, all these films are AP, okay? So that patient still goes to the operating room. The chest x-ray to me, and that's why I think more and more studies are being done across the country about whether or not that chest x-ray is even necessary really in the trauma bay, because nothing has ever changed management regarding the wide and mediastinum for us. What changes the management is whether or not the patient has a pneumothorax, and I've already described that that can be very easily and accurately identified using ultrasound. GCS is a gimme, so it's like if there is a multiple section, if there is one of those matching sections, which there isn't, but if there is a matching section on the examination, you would jump right to the matching section first, because those 20 questions are the easiest questions to get right away, right? You don't have to read all the long scenarios. And GCS is just something that just remember, commit it to memory. This is what we do. This is what a GCS table looks like. Not much more to say about it. Okay? This is an important slide for the physiology, and one that I know is familiar to everybody. Depending on the different types of shock, and you'll notice there's no such thing, there's no classification as septic shock. Septic shock is grouped together with neurogenic shock in a group called distributive shock, and the common theme there is that they have decreased systemic vascular resistance. All right? Everything else I think you can pretty much kind of reason out, right? I know that the practice paradigm is that very few people put PA catheters in anymore, but this is still important information from a physiologic standpoint, right, on standardized examination. So PA, pulmonary artery, OP means occlusion pressure. That's the quote-unquote wedge pressure, right? So if you're hypovolemic, you would have a low wedge pressure. If you're in cardiogenic shock in a very cartoonish fashion, there's no forward flow, so there's a backup effectively, and so now you have a high pulmonary occlusion wedge pressure. Cardiogenic shock, by the way, is not the same as necessarily a hypervolemic physiology, okay? So you've gone through the primary survey, you've done your appropriate adjuncts, including a chest x-ray, pelvic x-ray if necessary, as well as a ultrasound, and then you move on to your secondary survey, which is just a complete physical examination. And during the secondary survey, we then prioritize, assuming that you went through the primary survey, there was nothing that stopped you, right? In a very unstable patient in the trauma bay, they don't get their secondary survey until probably after you've gone to the operating room or the angio suite or whatever it was that you needed to address during the C for circulation. Then we get additional imaging as necessary in disposition. I know that those of you who've taken ATLS remember that that's also the point that you start transferring the patients to the next level of care. All right, so that's the sort of the principles and overview of trauma. Let's talk about traumatic brain injury. Here's the question, so get your clickers ready. The patient is a 72-year-old man with a history of atrial fibrillation on warfarin who presents after a slip and fall on the front porch steps. He does not open his eyes, withdraws to pain, and has no verbal response. Currently is intubated and brought to your trauma bay. His vital signs are 170/60, heart rate of 50, SATs 100%. Primary survey reveals breath sounds bilaterally and a negative EFAST. Right pupil is dilated and sluggish. Left is reactive. What is the next step in management? All right, a little bit of a split. So a bunch of you said 44% of you said a stat CT of the head. We'll come back to that in a little bit. So the answer we're looking for is give mannitol, 1 gram per kilogram IV. The recognition here is that the patient has become hypertensive bradycardic with signs of impending, really is already herniating, given the right pupil that is dilated and starting to be sluggish. So this is a recognition that this patient has impending herniation, okay? And so the patient that has impending herniation who's hemodynamically stable requires a osmotic diuretic, and that's in the form of mannitol. So those of you who wanted to get a CAT scan, strictly speaking, oftentimes these people probably do end up getting a CAT scan before anything's given to them. But on a standardized examination, you need to treat this problem before the diagnosis becomes available. Remember, that is one of the tenets of trauma management, is that not necessarily need the diagnosis, but remember that if you put the patient through the CAT scanner while they're impending herniation, that is going to lead to terrible outcomes. Okay. So, and then 17% of you said increased minute ventilation. This is to hyperventilate the patient. So, yet another measure to decrease intracranial pressure. We, as a paradigm shift, we have also started to move away from hyperventilation. We know it's short-lived. We know that hyperventilation, particularly beyond 35 millimeters of mercury CO2, is associated with actually ischemia, because all of a sudden you vasoconstrict so much that you are not getting enough cerebral perfusion. So the answer here is mannitol. Let me just, yeah, that's fine. Okay, so some statistics, right? Lots and lots of TBIs a year, over 1 million. A lot of them are elderly patients who fall. This contributes to the tremendous amount of money that we spend for our citizens towards the end of their life. There's $15 billion of productivity loss. Falls is a leading cause, particularly in the elderly, and then secondary, and followed by motor vehicle crashes. The primary injury, which is the direct impact, whether it's rapid deceleration, coup, contra coup injury, whatever the injury, it's done, right? That injury is done. And so again, to remind you that our jobs then in the trauma bay and the ICU is to minimize secondary injury. Okay, quick reminders to everybody about the anatomy of the spaces and how these bleeds happen, right? We must talk about epidurals, we must talk about subdurals, and then a little bit about subarachnoids, okay? So you recognize that the skull anatomy right down to the brain has multiple layers, right? You got the skull, and then you got the dura, which is this blue thing here, okay? So that's the division point between epidurals and subdurals, okay? And then the dura is split into two, either a pia or the arachnoid spaces. And again, that's almost like analogous to our visceral versus parietal pleura. That space between those two layers, the subarachnoid and the pia spaces, is a potential space unless there is bleeding, in which case it can expand, and that's called a subarachnoid bleed. Epidurals, epidurals is classically described as somebody that had a period of lucid interval between moments of altered mental status. It's classically associated with the disruption of the middle meningeal artery, and is usually associated with the skull fracture. It's got the lens shape. It follows contours. It can only push the brain away, and of course the skull forming the other side of the lens. The management usually requires evacuation, right? Particularly because it may be associated with the middle meningeal artery bleed. Subdurals, okay. So subdurals have this crescent shape to them, okay. They're usually associated with bridging veins. There are veins, veins under pressure, usually tamponades off. A lot of these patients do not get managed operatively anymore. The Trauma Brain Foundation, which is the society that actually incorporates people from the Neurosurgical Society, these are their guidelines that if there's greater than 10 millimeter thickness or greater than 5 millimeter midline shift, that the patient should in fact get surgical management. In 2016, that's a very, that's a very loose guideline. Clearly, lots and lots of patients are not getting drained for subdurals. Okay, these are acute patients, by the way. They're very different than chronic subdurals, and I don't think the chronic subdural is a subject of a general surgical board's examination. Okay, but if a clinical scenario suggests to you that the patient is deteriorating from a neurological status, or that the patient comes in with findings greater than 10 millimeters of thickness or greater than 5 millimeters of shift, that's somebody that needs neurosurgical intervention. Here's subarachnoid bleed. We talked about it a little bit. I frequently associate subarachnoids with underlying contusions. And while the subdurals and the epidurals look dramatic because of the amount of collection focally, what's more concerning to me from a neurological standpoint are the patients with the contusions and the subarachnoids. And the reason is because what you're seeing at the initial presentation CAT scan is but the beginning. It's the tip of the iceberg. Those people are going to swell. They're just like if you banged your knee, you're going to get swollen after a while. They will swell in their brain. I find these patients actually more challenging to tackle. Okay, we talked. Just to describe this to you already, the subarachnoid space. All right. So what about skull fractures? So a question may come up about what do you do when a patient has a depressed skull fracture, right? So the standard answer still is, particularly this depressed skull fracture, is the displacement is greater than the thickness of the skull, which isn't very much of anything, requires operative elevation or decompression. Okay, so here's the indication list for elevation debridement for open skull fractures. If you think that there's dural violation, if it was a really, really dirty wound, if you have significant pneumocephalus on the CAT scan of the head, or the depression is greater than the skull thickness, this patient needs antibiotics, number one. Number two, needs to go to the operating room to have decompression, to debridement and elevation of the skull. All right. So initial management of TBI, right? So it's the same ATLS protocol. The D part is for the D part of the primary surveys where we sometimes get stuck on patients with traumatic brain injuries, especially that patient that we had in the clinical scenario who was having an impending herniation, right? GCS of less than 8 is considered a severe traumatic brain injury. It's comatose. That patient needs to be intubated. And in fact, if your scenario has a patient who comes in as a GCS of less than 8 and the patient is hypotensive, is tachycardic, the next step management is not to EFAST or exploratory laparotomy. It's to obtain a secure airway. Okay, so the step one is airway. Even though the patient's hypotensive, tachycardic, you think that there's massive bleeding going on. Okay, so if the patient needs to be intubated, that's the ABCs. Subsequent to the initial injury, like I keep saying about the secondary injury, what we're really looking at is avoiding hypotension and hypoxia, right? That's one of the reasons why all of our trauma patients, when they arrive, they get oxygen. Never mind the fact that it also helps with myocardial consumption, but patients need oxygen, and hypoxia and hypotension are the two most strongly predictive of outcomes for traumatic brain injury. Secondary injury, right? So again, main goal of the post-traumatic brain injury patient is that we want to prevent hypotension, hypoxia. There's very little we can do necessarily to control the amount of swelling as a result of their contusion, their subarachnoid, but we certainly do our best to try to prevent halting or to slow down that process if we can. And we definitely don't want to contribute to that process by having a hypotensive patient who's not getting enough cerebral perfusion pressure, okay? Like injury anywhere else, our body reacts to stress in a very, very similar fashion. Whether it's cardiogenic, hypovolemic, whatever shock it is, it sends off the exact same cascade of inflammatory processes, and that cascade of inflammatory processes unfortunately go unchecked in our trauma patients. They get free radical injury, they get cellular death, mitochondrial dysfunction, which is incredibly dangerous, and that's what leads to continued increased swelling locally, right? So that tiny little ditzel of a subarachnoid can turn into quite a bit of a contusion with edema and ultimately lead to intracranial hypertension. So signs of impending herniation, just like the gentleman that the scenario that we just looked at, that was a classic description of a Cushing's reflex, right? Somebody who becomes hypertensive, bradycardic, and it maybe has signs of impending herniation, like one-sided. Well, why did that patient, by the way, have only one-sided pupil that was fixed and dilated? Well, it's because it was pulling down cranial nerve on that side alone, right? So pretty soon the other pupil will follow as well. We talked about pupillary dilation and fixation. Posturing is a very, very late sign. I would argue if the patient didn't posture before and is now posturing, we probably missed the boat. There was probably a window where we should have been able to pick up that the patient has signs of impending herniation. I always, I think there's a question about it later, so I don't want to spoil the surprise. So this is a Monroe-Kelly doctrine, right? Because our skull space is a very fixed volume, something has to give. And the components in the skull are, right, blood, brain, and CSF. Okay? Something has to give. So if your brain swells, there's a real convenient outlet for things to decompress, and that's called your brainstem, right? So there's a big hole at the base of the skull, right, that leads into our spinal cord, and that's where things want to go to decompress. All right. So you would say, well, there are other ways that we can decompress. We can take the entire skull off. We can actually do it on both sides, and we have done that. Again, that's less and less in favor now because the outcomes are terrible for those patients that get both of their skulls taken off. Okay. So there's very little we can do except to decrease the amount of intracranial hypertension. ICP monitoring. All those things that we talked about with all the mechanisms to decrease intracranial hypertension, like hyperventilation, osmotic diuretics, we used to be quite aggressive with those things. And it wasn't until we recognized that the real important thing is none of those markers, but is in fact the cerebral perfusion pressure, which is mathematically the difference between your mean arterial pressure and your intracranial pressure. right? So how do we know if the societies are recommending that we treat to a certain cerebral perfusion pressure, and we don't know what the intracranial pressure is, how do we measure the cerebral perfusion pressure? That's a great question. I don't know the answer to that, right? Because nowadays, also in 2016, many centers are foregoing ICP monitoring because there's no prospective randomized trial. Much like, actually, as you all know, there's very few prospective randomized trials that guide us in general surgical practice. But the idea is that if we're to treat to a cerebral perfusion pressure, then we need ICP monitoring, right? So we know half of the equation. We know the map. We don't know the ICP. So that's one of the indications for ICP monitoring. Okay? All right. Management of intracranial hypertension. This is an important concept, right? So we want to try to keep our ICPs down to below 20 millimeters of mercury. So what's all of our ICP sort of sitting here? It's actually not 12, right? It's probably something like 6, 8, right? And if this is, and all this information that's happening, that's being put forth to you this couple of weeks makes you a little bit agitated. Maybe it goes up a little bit, but it's not anywhere near 12. But 12 is that magic number that we've settled on, right? And so we give a little bit of leniency and we say, well, there's really no difference if I were to really tightly control the ICP down to 12. So we're going to do ICP of 20. Okay, but the most important part of that sentence is that you want to maintain your cerebral perfusion pressure between 50 and 70 millimeters of mercury. Okay, so all of these maneuvers matter. Okay, all right. Elevation of the head, craniectomy, hyperventilation. Hyperventilation, by the way, is very short-lived. Okay, sedation, coma, paralytics, osmotic therapy, and hypothermia, which is controversial, but it is done for patients with traumatic brain injury. Hypothermia in general, even if it doesn't come up in a trauma context, it's tough for us surgeons because post-op, especially our fresh post-op patients, is usually listed as a relative contraindication to hypothermia, right? Because these patients will bleed, and we don't want our patients post-operative to bleed. So hypothermia has always been hard for us to do in surgery. This is the corollary of the Monroe-Kelly doctrine, which is that the cerebral perfusion or the cerebral autoregulation, we're very lucky. We're designed in such a way that we can tolerate a huge swing in our mean arterial pressure, right? Draw your attention to the x-axis. The x-axis looks at the mean arterial pressures over a wide range, and you notice that the y-axis is the cerebral blood flow. This, when I talk to the residents, I always tell them these are the asymptotic graphs of life, right? Every physiologic graph looks like this. You can put any X and any Y relationship, and this is how our body works. So our cerebral blood flow actually is maintained very, very constant over a wide range of mean arterial pressures. Now look at that dotted line. That dotted line are patients with traumatic brain injury. They no longer have this auto-regulation in place. And so every bit of increase in your MAP becomes a direct increase in your cerebral blood flow, which then translates to increased intracranial pressure. Okay, that's the danger of losing your cerebral autoregulation. All right, another question. This time, the patient is a 40-year-old woman who is involved in a rollover MVC with a prolonged extrication, who is comatose in the field and intubated by the EMT. On arrival, the blood pressure is 80/50 with a heart rate of 120. Pulse ox is 96%. Her pupils were initially reactive, but now is very sluggish to becoming fixed. Her EFAST is positive with fluid in the spinal-renal fossa. The next step in management is all right, good job. Okay, exploratory laparotomy. All right. Okay. Now, totally understandable the choice for E. Edward for mannitol, but let's just talk about exploratory laparotomy. All right. I'm here talking about trauma not only because that's what I do day to day, but it's because it's one of the favorite topics of general surgery boards. It's one of the favorite topics, and one of the favorite topics within trauma is always prioritizing, right? It gives you a really complex patient, and you have to prioritize, and you have to go, well, what do I do first? And so on this list of patients, the patient is intubated, but it's hypotensive with a positive FAST, okay? So you can pretty much ignore the rest. If I saw that on in fact, when I go scan these questions, I just go scan for hypotension and positive FAST, and then I just go and look for the answer for exploratory laparotomy, all right? That's always going to be the answer. We don't stop to do anything else. No CAT scans of the head. Now, Mannitol is an interesting concept here because 25% of you, a quarter of those who answered, recognize that this patient is herniating. Okay? All right. And this is really the slide that I wanted to get to from earlier to make a point, a very important point. Right? I would say that trying to give somebody an osmotic diuretic in this situation is actually a good thing because you're going to probably do the both at the same time, right? You're going to try to push your mannitol and wheel the patient to the OR at the same time. But there is a problem using mannitol in this patient, and that's because the patient is hypotensive. Okay? So we do not use mannitol in hypotensive patients who have impending herniation, right? What are our options at that point? What else could we use? Hypertonic saline, I think I heard somebody say. Okay, so nowadays many trauma centers actually store 3% or 23% saline in their trauma bays, so that if a patient comes in, that's a great use for hypertonic saline. Somebody who's hypotensive, impending herniation, you're rushing them off to the OR for XLAP, right? Hit them with a little bit of 3% to give them the diuresis you need, but without losing the necessary volume. So it's not a diuretic. I misspeak, but the reason you're giving the hypertonic is to do what? Is to draw fluid out of the cerebral perfusion, right? Out of the cerebral edema. Does that make sense? So we're trying to take that away. It's a similar concept to the hyperventilation. It's different than a mannitol because the mannitol is going to induce quite a bit of a diuresis, in which case you're going to make the patient even more hypotensive, which then goes against our tenet of trying to maintain cerebral perfusion pressure. Okay? Hopefully that makes sense. And these are the more common questions that test your ability to prioritize. All right, let's talk about cervical injuries. Okay, question time. Definitive indications for computed tomography angiogram, CT angiogram, to evaluate for blunt cerebral vascular injury include all of the following except. All right. I know that on the real test there are no except questions, but I always wait for about 20 responses and then I click the thing to give everybody a chance. Okay, so 58% of you chose expanding traumatic neck hematoma. Yeah, so the correct answer is actually E, transverse process fracture of the cervical spine, which is of no clinical consequence. In fact, many of us would not even call spine surgery to have the patient evaluated if we were not in such a medical legal society. These patients do not need a spine consult, transverse process fractures. Okay, all right. So the A, B, C, and D are all absolute indications because they're telling you that there may be a hard sign, there may be whatever the mechanism is, it was strong enough that it led to it could potentially lead to a blunt cerebral vascular injury. Okay, so so the answer is transverse process fracture of the cervical spine does not make me believe that the patient is at increased risk for a blunt cerebral vascular injury. All right, so Eastern Association, there's East, there's West, there's AAST, there's lots of associations for trauma, but I just stuck with one. They're all pretty much the same, okay? The Denver modification of screening criteria for high-risk patients who you think may have blunt cerebral vascular injury, clearly signs and symptoms of blunt cerebral vascular injury leads you to believe it. What does that mean? Well, signs like they're having a stroke, I guess, right? Because their carotid or their verts or vertebrals have been damaged somehow, whether it's an intimal disruption, whether it's a dissection, whether it's truly a transection, any arterial hemorrhage, particularly in penetrating injury, cervical bruit. Cervical bruit will tell you that there's turbulent flow, especially, right? Our vascular surgeons in the audience know that very well. Expanding cervical hematoma, focal neurological deficits, and then of course this is an interesting one. When you have a CAT scan, it's like the CAT scan looks completely normal, yet your neurological exam is not normal. You have to work this up further for a potential blunt cerebral vascular injury. Okay. So risk factors for blunt cerebral vascular injury are the high energy transfer mechanisms, right? Lefort 2 or 3, Lefort is a classification for facial fractures. And Lefort 3 fracture is a craniofacial dissociation, right? So whatever mechanism that caused that crush of a face is probably high enough impact mechanism that it could lead to blunt cerebral vascular injury. Cervical spine fracture pattern. So specifically high fractures in C1, C3, right? Fractures that extend into the transverse foramen, not the transverse process. Basilar skull fractures, we always are anytime we see a basilar skull fracture, we're concerned about a constellation of things, obviously including spinal cord injury, including traumatic brain injury, and then certainly blunt cerebrovascular injury. Any patient with diffuse axonal injury, so let's say they're 3 days into the ICU stay, right? They're not waking up. You don't understand why they're not waking up because really their CAT scan was not all that impressive. Well, as you know, diffuse axonal injury is not picked up on CAT scan very well. We could see some swelling the next few days. If it's later on diagnosis, the patient had diffuse axonal injury, then we have to at least look for BCVI. Okay, and then of course near hanging with anoxic brain injury. This is the continued list. Not to necessarily remember it, but just remember that if a patient has a high impact mechanism, if the patient has a significant cervical spine injury or base of skull injury, you need to look for a blunt cervical vascular injury. Okay, nexus criteria, right? So nexus criteria is a very well accepted set of criteria for us to be able to remove the collar on a patient without further imaging. Okay, so these patients are patients who don't have any pain, who are completely with it, oriented, right, not intoxicated, who have no neurological deficits. And of course, the most subjective of it all is no distracting injury, because no distracting injuries. Now, I've had patients who have literally bruised their abdominal wall or tiny little bits, and it's considered distracting to them because they just can't focus on your examination. Okay. Cervical collar clearance in an obtunded patient. This is still controversial. EAST actually just put out the most recent practice management guidelines, which is to say that if your CT scan is negative for any injury, it has almost 100% negative predictive value, which we're going to get to. I always want to review the stats with you a little bit in case it comes up on the examination, but it has a 100% negative predictive value, which means that if the test is negative, you probably don't have the disease, right? That's negative predictive value. So if your cervical spine is CT scan is negative for injury, it's unlikely that you have a clinically significant unstable cervical injury, okay? Doesn't mean you don't have necessarily some potentially for some ligaments that are strained, but it's not going to be clinically significant, and it's not going to be unstable. Let's move to another scenario. This is a 73-year-old man with DJD, degenerative joint disease, who sustains a whiplash and a rapid deceleration MBC. The exam demonstrates flaccid upper extremities, but preserved motor in the lower extremities and some variable numbness, just this kind of patchy numbness below the nipple line. And the diagnosis here is very good, central cord syndrome. Okay, so these are the annoying cord syndromes that we had to remember when we were residents, but they rear their ugly head again for recognition of these cord syndromes. All right, and I'll describe to you in a little bit. So this is central cord syndrome. Central cord syndrome is classically described in patients who have particularly cervical DJD because of pre-existing canal stenosis, and that's usually associated with some sort of an osteophyte, right? And this is usually associated with a hyperextension injury, which is what happened here. Okay, so central cord, I already kind of talked about this a little bit. Because of the distribution, I'll have another slide on this, because of the distribution of the important tracts, right? The 3 tracts that you should be familiar with and commit to memory are the spinal thalamic tracts, cortical spinal, and the dorsal columns. And I have always had trouble just trying to rote memorize these, but I could always remember by drawing myself one of these little pictures where those tracts are, and then I go, okay, well, got to knock this out, then this is what happens if you knock this side out, or this is what happens when you knock this out, right? But the central cord syndrome is that you have a preferential loss of motor strength in the upper extremities and to some variable degrees of preservation in the lower extremities. The sensory loss is not in any sort of a dermatomal pattern, and this is due to a hyperextension injury that we talked about in somebody who had pre-existing or risk factors for cervical canal stenosis, classically diabetic or elderly patient with DJD. Okay, this is somewhat better prognosis than the other injury syndromes. Okay, spinal cord syndromes, I just want to point this out to you, right? The dorsal column gives us our proprioception and our a vibration sense. The cortical spinal tract and the anterior horn, which I just kind of grouped together, is motor. It controls your motor, right? Spinal thalamic tract controls your pain and temperature. So all you got to do is remember dorsal column, draw yourself a picture, dorsal meaning the back, the anterior columns, and then the cortical spinal tract. And then you can pretty much figure out what happens when you knock things out, all right? This one is a little busy. I just put it in there so that you have it in your slide. But let me just go back to this previous slide. So let's just look at anterior cord syndrome for a second, because that was one of the choices on the previous slide, right? Anterior cord syndrome, it's a little bit of a misnomer because the anterior cord actually extends all the way over here. The anterior cord, the anterior horn, includes the cortical spinal tract. So if you have an anterior cord syndrome, you're going to have ipsilateral motor loss, right? Ipsilateral motor loss, ipsilateral pain and temperature loss, okay? If your dorsal column was knocked out somehow, right? Let's say that you were doing vascular surgery and your dorsal column was knocked out, you'd have problems with proprioception and touch, okay? And then the Brown-Séquard cord that everybody's probably very familiar with, it's just the crossing, depending on the crossing. So you have ipsilateral motor, contralateral pain and pain and temperature sensation. Okay, all right. So, not that you have to commit it to memory right now, but just be familiar with those syndromes. So again, we go back to EAST guidelines for blunt cerebral vascular injury. There's no especially there are trauma surgeons in the audience, there is, to my knowledge, there's no prospective randomized trial based guideline on what we should do with patients diagnosed with blunt cerebral vascular injury. And frankly, I don't think it's ever going to get done because we don't have enough numbers to support that type of a study, even if it's many multi-center trials. Okay, but bottom line is we do antiplatelet therapy. It's no better or no worse than doing a heparin drip. So we go with the easiest thing, which is aspirin. 325 milligrams is all you need. Okay, these patients don't need to be on Plavix. They don't need to be on a heparin drip to permanent anticoagulation or bridging over to Coumadin, to warfarin. Okay, so I don't know what to tell you. If the answer choices have both aspirin and Plavix, I would pick aspirin because that's a risk-benefit analysis, all right? Because, right, increased likelihood of bleeding with Plavix as opposed to aspirin 325, and Plavix is not known to be any better. So I would still pick aspirin if I were faced with that question. For pseudoaneurysm occlusion and transection, so our particular vascular colleagues probably have a lot of experience with endovascular. That's the wave of the vascular future. The carotid, though, the body of literature and the experience on carotids have not been quite so paradigm changing as it has been for the intra-abdominal thoracic portions. But the societies do recommend considering endovascular approaches should there be a pseudoaneurysm, complete occlusion, or transection, right? For intimal disruptions, dissection, or intramural hematomas, CTA is now the gold standard, okay? The gold standard has always been invasive angio, but as you know, with our 64 slicers, very few people are actually doing invasive angios for diagnosis. Okay, clearly there's a role, obviously, there's a role for invasive angio, but our CTAs are just as good. Okay, and we do a follow-up CTA within 7 days of the diagnosis just to see whether or not the different gradations of blunt cerebral vascular injury can progress. So you had a little bit of intimal disruption, or you had a greater than 25 or less than 25% stenosis of your canal of the blood vessel. That might have progressed as disease progresses. Okay, penetrating neck injury, classic zones from the cricoid to the mandible. From the manubrium of the sternum to the cricoid to the angle of the mandible, and then everything above the angle of the jaw is zone 1, 2, and 3, respectively. Hard signs of major neck injury that demands after penetrating trauma. So there was a time where all penetrating trauma neck injuries were explored, right? That's not the case anymore, I think the most standard answer is now a selective approach to penetrating trauma of the neck as defined by platysma violation. Okay. Now, having explored some necks for penetrating neck trauma, I'll tell you that it's pretty hard to definitively know in the trauma bay while digging around in that wound whether or not there was platysma violation. So the practical approach to it is if you can't figure out whether there's platysma disruption, you assume there's platysma disruption, and the standard answer will still be to go and explore the neck. Okay. Now, these are absolute indications whether or not there's a platysma disruption. And frankly, if you see these signs, there definitely was platysma disruption. Any active bleeding, expanding hematoma, a bruit to suggest that there's turbulent flow, once again, with intimal disruption or something's wrong with the carotid system. Significant subcutaneous emphysema, respiratory distress, and neurologic deficit. I want to stress the last two, respiratory distress, stridor, hoarseness, neurological deficit. I just want to stress that I hope by the time that you got to this point, the patient was already intubated in the clinical scenario, right? Because that's the A of the A, B, and C, D patient, okay? And then these patients necessitate operative exploration. All right, zone 1, so zone 1 is down here, right? Or sorry, up to here, is treated like thoracic injuries. And the risk of zone 1 penetrating neck injuries is very, very similar to thoracic injuries in terms of aerodigestive system, in terms of major vascular structures that could be potentially injured. Zone 3 is like a TBI or head injury. It's hard to access. Nobody gets all the way up there to do anything about it, so it's rarely operated on. Zone 2 injuries have traditionally been accessible, because we can get to it, and that area can be explored. I want to bring up some other points. Zone 2 is an area of controversy. We talked about how most people are now doing selective management. Okay, all right. So if you don't explore the patient, that doesn't mean you don't go looking for things, right? So if the answer choice has pan endoscopy, for example, a pan endoscopy as an option, then that is a potential. That is, and I don't know what the other options would be, but if you had a pan endoscopy as an option, and you had neck exploration as an option, I would select pan endoscopy in that situation, because the standard now is, particularly in somebody with no hard signs of penetrating neck injury, that you should be selective about invasive procedures. I also think that despite the fact that it's a surgical examination, the answer is always going to be all the choices listed there. The answer is always going to be choose the least invasive that's going to get the job done. Choose the least invasive study that's going to get the job done. Okay, CTA over operative angio, okay? Ligation of jugular vein for complex or unstable injuries is totally acceptable. Most arteries, though, should be repaired. Generally ill-advised to tie off a carotid, but although it has been done. Facial injuries. So there you go, Lefort fractures, just to say that, you know, as you go towards the left side of that, sorry, to the right side of that slide, Lefort 3 is a craniofacial dissociation. And why is that important? Remember a couple of slides back, I don't really care about the facial fractures per se, right? Because the facial fractures are not all that life-threatening, but this patient is at high risk for blunt cerebral vascular injury. The answer choices will have what additional studies need to be done or whatever, and your additional studies need to be CTA, okay, of the neck. All right, let's get to another question. 30-year-old man sustains a crush injury to the face from an I-beam, ouch, at a construction site. During the secondary survey, you find significant mid-face instability, and the CT head and face demonstrate a craniofacial dissociation, aka Lefort 3. What additional workup is necessary? Oh, I think I just did this. So we should get 100% correct. All right. %. Okay. Let's say 2% of you said ultrasound evaluation of the carotid, 2% said triple endoscopy. So definitive diagnosis will require a CT angio, because here what we're asking about is blunt cerebral vascular injury. Thoracic injuries, okay? So thoracic injuries, very common, 10%. Vast majority of these are rib fractures, okay? 2.5 million trauma admissions a year, 20% of all deaths are related to thoracic injury, mainly because, not actually because of the rib fractures, because of the great vessels that are there, because of pulmonary contusions that happens afterwards, and these patients have potentially complicated ICU courses. Lots of money are spent on thoracic injuries, okay? All right, so now we don't call it cardiac contusions anymore, it's called blunt cardiac injury, okay? So that standardized terminology for what we used to consider blunt cardiac or cardiac contusion. And the reason is because it's but a spectrum of diseases, and cardiac contusion is sort of like one dot on that spectrum. Anyway, so the blood cardiac injury risk factors are the same as any other ones. It's a high impact factor because theoretically the sternum should be protecting it, right? They're usually motor vehicle crashes, pedestrian strokes, classically steering wheel, right? Somebody, the airbag didn't go off, or even sometimes, actually I had a patient who's really, a petite woman who was sitting just a little too close to the steering wheel, and the airbag went off and it like blew her out of her chair because she was so small. Broke lots of things. So the thing that was, and probably if the airbag didn't go off, nothing would have happened really, because she was she was going to be okay. Regardless, her injury was by the airbag, and she did have blunt cardiac injury. Right ventricle and the right atrium are most likely involved. Why? Because they're in the anterior position. The right ventricle is very, relatively speaking, compared to the left ventricle, relatively weak muscle. Associated injuries, not a surprise to you, right? Rib fractures, sternal fractures, pneumothorax, hemothorax, and pulmonary contusion. We'll get back to the sternal fracture point in a little bit. Clinical manifestations may be very subtle. You're not necessarily going to see somebody who's dramatically hypotensive, right? And Beck's triad of listening for distant muffled heart sounds and distended jugular veins. By the way, I have never ever seen distended jugular veins, and I don't know why. Maybe it's just my practice. I've never seen it. But clinically significant blunt cardiac injury, it may lead to cardiogenic shock. So you should suspect that there may be blunt cardiac injury if the patient is in, and you ruled out all sorts of other bleeding if you recall back to the initial discussion. Blunt cardiac injuries, everybody gets an EKG who's suspected of blunt cardiac injury, right? If the EKG is abnormal, we admit the patient for continuous monitoring. Now here's the kicker. If the patient is hemodynamically stable and the EKG was normal, you can discharge them. Well, what are the chances of you discharging somebody with somebody that had a mechanism that was strong enough for you to suspect blunt cardiac injury? So that's usually the rate limiting factor. Okay. If the patient is hemodynamically unstable, those are the only patients that require echo. So not everybody needs an echo. Okay. CKMB is not helpful, so don't get CKMBs on patients. A normal EKG and a negative troponin effectively rules out a blunt cardiac injury. Okay. That has a near negative predictive value of 100%. All right. Cardiac tamponade. We talked about Beck's triad, right? Hypotension, distant heart sounds, and jugular vein distension. Now, pulsus paradoxicus is an interesting physiologic phenomenon. Normally, when we take a deep breath, we decrease our intrathoracic pressure and then increase venous return, right? So once we increase venous return, we usually have an increase in our cardiac output. And if you hold systemic vascular resistance stable, you have a little bit of bump of your cardiac output, right? But not so when you have cardiac tamponade. And the reason for that is because the septum, all of a sudden you have all of this increased right inflow from venous return. The septum encroaches into the left ventricle. There's no space for that heart to expand because now you have cardiac tamponade, and so all of a sudden you have decreased LV filling. Once it results in decreased left ventricular filling, all of a sudden you don't have as much of a cardiac output. All right, so it's an interesting phenomenon, and it's a drop of 10 millimeters of mercury on your systolic blood pressure when the patient actually takes or inspires. All right, here's the quick stats thing that I promised. All right, so if you have trouble visualizing what the sensitivity, specificity, negative predictive value, positive predictive value, just draw yourself that little 2x2, right, of the disease and the test itself. Negative predictive value is D, which is that your test is negative, means that you're likely to be disease free. Okay, over CND. So you can calculate that value, but bottom line is that a negative predictive value tells you, so 100% negative predictive value tells you that if the test is negative, 100% of the time, you do not have the disease, okay? Positive predictive value is sort of the other way, right? So if your test says that you have a positive test, that you have 100% likelihood, if it's 100% positive predictive value, that you have 100% likelihood of having that disease, okay? And you can just draw yourself a little 2x2 and then you can figure it out. All right, flail chest, right? Multiple segments, rib fractures, multiple rib fractures and multiple segments, and each rib fracture makes your chest unstable, and then you get this paradoxical motion. When we normally take it, or when we take a nice deep breath, when we inspire, our chest wall comes out, right? But in paradoxical motion, that component that is detached actually depresses, which is obviously not good for pulmonary physiology. When you're presented with a patient who's hypotensive and hypocapnic, you look at the patient and you say, what's going on over here in this chest x-ray? And you're seeing that the airway is actually shifting over to the left side of the patient and right side of the screen, right? So this is a mediastinal shift due to a tension physiology, and of course the treatment right away is a chest tube on that side, okay? On the right side. Tension physiology. So tension physiology, again, tension pneumothorax is not a radiographic diagnosis. It is a physiologic diagnosis. But it does end in tracheal deviation, mediastinal shifting away, jugular venous distension. And the bottom line is that all the physiologic parameters that are associated with tension physiology is because of decreased venous return. Okay. Can you imagine a patient that has tension pneumothorax and cardiac tamponade? They'd have both. They'd have the worst of both worlds with a decreased venous return. Now, thoracic injury. Okay, so take a look at this. And you look at this X-ray, and you look at the usual places, and it's particularly in the apex of the chest X-ray. You don't see a pneumothorax, but this is called a deep sulcus sign, right? Look in the left lower costal phrenic angle. You see how I don't know how well it's projecting, but it goes way down here. It's got a really sharp costal phrenic angle. If there's a clinical picture that makes you suspicious that there's a pneumothorax, particularly in a supine patient, look in the left costal phrenic angle. This is called the deep sulcus sign. And the reason this happens is if you're not standing up, that air, the pneumothorax, is not going to go to the apex of your lung, right? If you're supine, it's going to layer out in the anterior position. Clearly, if you got a CAT scan right now with cross-sectional imaging, you'd easily be able to tell that there was an anterior pneumothorax. We know that rib fractures, the rib fractures in and of themselves are not as big of a deal as we used to think. Clearly, it causes a lot of pain, so that the pain makes people not want to take deep breaths. People who don't take deep breaths, then they get pneumonias, right? But even more important than that, the rib fractures can cause the bruising of the lung underlying, or the pulmonary contusion, which was very early described, and it's probably not the first time it was recognized, but it was described in the literature in 1965. This was a time when trauma centers were whichever hospital were closest to the highway, not tertiary centers in the downtown area. Right, and so back then they already recognized that injuries associated with pulmonary contusions are listed right there. Okay, and if you look at this, if you look at a picture like this is not a hemothorax on the left side of the patient, right side of the screen, right? This is likely a pulmonary contusion. And if you were to get, and that sometimes is hard to tell, right? So if you were to get cross imaging, it looks like liver, right? Because what's happened is that the alveoli have all now been consolidated with lots and lots of debris. Those are not ventilating components anymore, and so it looks like solid lung as opposed to air filled. Okay. In fact, if it were on both sides, this is what ARDS would look like on cross imaging. Okay. And also, if you note this tiny little apex or tiny little pneumothorax right here. All right. And what's the pathophysiology behind what's so bad about pulmonary contusions? So on the increase side, or the worsened side, you have worsening VQ mismatching, right? The V is being affected. The V is being affected because you have now atelectatic portions of the lung. You increase intrapulmonary shunt. You have increasing pulmonary edema because, like anything else that you bang up, you're going to get edema from it. That increases pulmonary resistance. You have increased mucus production and bronchospasms, right? And then coupled with decreased ability to diffuse your CO2, again, because of all the debris that's in the alveoli, decrease in surfactant production, decrease in pulmonary compliance, and you end up with a patient who looks as sick as what we expect for somebody with bad pulmonary contusions, and that's somebody who's hypoxic, hypercarbic, and increased work of breathing. So they're not ventilating, they're not oxygenating, and they look like they're using accessory muscles to breathe. This is a busy slide. There's nothing to remember except to know that when your alveoli or alveolus is injured, this is pretty much what it looks like. It's just all filled with debris, right? Lots of things go in there and try to fill it. Well, if it's filled with all of that stuff, that looks quite messy on this slide, right? It's not oxygenating. It's not ventilating. It's not diffusing CO2 across it. Okay, and in fact, that's why on that cross-sectional image, that alveolus looks like looks like a solid organ.
All right, secondary injury, right? There's been studies in the lung. Unfortunately, that's why ARDS is still so prevalent. We don't have a really good handle on it. We support it very well, right? We have goals of low tidal volumes to treat ARDS, but we can't. We can't get a really good handle on it. The reason is because, like I mentioned earlier, whenever you have stress, injury, trauma, shock, whatever, all the inflammatory processes go around, and they go systemically, right? And the lung have no filtering mechanism, so the lung is, even if you just injure the left side of the lung, because of the systemic process, which has been documented in animals, that the other side is affected as well. Okay. The reason for serial chest X-rays for people with rib fractures is because on presentation, only about 50% of pulmonary contusions show up, right? So you get a follow-up chest X-ray when you admit this patient because they can blossom, just like the traumatic brain injury patients. And the management of his pulmonary toilet, fluid resuscitation to be very, very judicious with your fluid, mechanical ventilation, steroids and antibiotics. We'll talk about a little bit about where we are in terms of management. So pulmonary toilet is the most important thing. Whether you want to do an epidural versus a paravertebral block, I would pick the answer for pulmonary toilet to say that, particularly in elderly patients, to use some sort of an adjunctive measure besides narcotics to get adequate pain control in pulmonary toilet. So epidural improves pain perception and pulmonary function. We don't know whether or not paravertebrals are better than epidurals. I hope it's going to be either or kind of a thing, not both on the thing. All right, so here's the next question. So 45-year-old man who's in the trauma bay after a high-speed MVC, somebody already answered, going at 85 miles per hour, unrestrained, respiratory rate of 25, normal blood pressure, heart rate is 115, GCS of 7, who is initially demonstrating respiratory distress, diminished breath sounds on the left. You place the left chest tube. The patient was intubated. The chest tube was removed on day. The chest tube was removed because there was no pneumothorax. But on surgical ICU day number 4, the patient becomes difficult to ventilate. The mean airway pressure increases to 40, and the next step in management is. Okay, so 56% of you rather wanted to get a stat chest X-ray, which is the answer we're looking for, and 36% said to reinsert the chest tube. So this is an interesting concept, right? Because 36% of you are thinking, well, we pull the chest tube out, so maybe another pneumothorax occurred, or something that was not clinically significant but is now clinically significant, maybe because you're thinking the patient's on positive pressure ventilation. So I think those are all reasonable thoughts. The stat chest X-ray gives you a lot of information, doesn't it? It's going to tell you whether or not you have a stat. It's going to tell you whether or not the patient has, in fact, a residual pneumothorax. But most importantly, it's going to help you identify whether or not the patient has a diaphragmatic hernia. Okay, and the classic presentation, I know that some of the scenarios seem very cartoonish and not very real life because they're obviously trying to demonstrate something, but diaphragmatic hernias are incredibly difficult to diagnose. They're very difficult to diagnose even on 64 slice CT scanners, and although we're increasingly better about it. And they're incredibly difficult, which is why to diagnose when the patient's on positive pressure ventilation. Okay, when you have a diaphragmatic hernia, the thoracic abdominal gradient is gone, right? Because there's just a hole there, and there's equilibration of pressures. But when you have positive pressure ventilation, it actually maintains that gradient, so you don't see the diaphragmatic hernia, all right? And then additionally, this patient had a chest tube in place, and you remove that chest tube, allowing that gradient to get even a little bit worse. All right. So for diaphragmatic hernia, it's called a pleuroperitoneal pressure gradient. Its associated injuries are very high mechanism, likely something else happening in the abdomen. We diagnose a fair amount. I mean, if you're in the operating room already, you're looking for a diaphragmatic hernia anyways. Okay. You just take a quick look. It's all there. If you see a diaphragmatic hernia, you must repair it. We have good experience doing it laparoscopically. It doesn't really matter. However you fix it, just try to fix it. Sometimes it's diagnosed so late that you might actually have to get the thoracic surgeons involved and do it from a thoracic approach. The most important thing is have a high index of suspicion, right? Because imaging is only obvious with herniation, like this X-ray. Right? You see this X-ray, and all of us would go, "Oh, yeah, that's probably a diaphragmatic hernia." Okay, but even multi-detector, though promising, is not great for diagnosing this. Intubated patients, like our clinical scenario, are difficult to diagnose due to the positive pressure in the chest. And the role of diagnostic laparoscopy, it's got 88% sensitivity and 100% specificity. Some colleagues would say you should if you have a suspicion of it, pop a camera in there through a tiny little port and take a look to see. And I think that's very acceptable practice now. So diagnostic, don't be afraid to choose diagnostic laparoscopy for trauma patients. Although never choose diagnostic laparoscopy for a hemodynamically unstable patient who you suspect who has a positive FAST. That's always going to be exploratory laparotomy. Okay, it's not yet standard of care to do a laparoscopy in those type of trauma patients. Okay, watch the phrenic nerve during your repair. Phrenic nerve, just like we do if any of you who've ever done a resuscitative or ED thoracotomy recognize one of the things we always look for is the phrenic nerve, because you've done all these things to try to save the patient's life, and then they wake up with a paralyzed diaphragm. All right, esophageal injury. Okay, mechanism of injury. It's pretty hard to get blunt esophageal injury, even though technically it is tethered in multiple places, right? The organs, the viscous that gets injured are those that are tethered. This is why your small bowel rarely gets involved. That's rarely gets injured. Just whatever is tethered is more likely to, especially in a rapid deceleration type of a mechanism. So it's very rare. We hardly ever see it. It's usually associated with other injuries in the thorax. So the approach is, to understand the approach to this on the exam, that if you have an upper or middle thoracic esophageal injury, that you need to go to the right side of the chest, right? Not a left thoracotomy. For distal esophagus, it's a left thoracotomy. For cardiac airways injuries, take precedence over the esophagus, always. Okay, the earlier the better, right? If you weigh more than 24 hours, you're going to do the most conservative thing that's listed as a choice. You don't want to be a cowboy or a cowgirl and do all the, primary resection, anastomosis, or worst off, if it's a delayed diagnosis, whether it was because of EGD or blunt trauma, you decided to just sew it and put some chest tubes in. That is not advised for the exam. Okay. So if you're over 24 hours, you're going to do proximal diversion, leave lots of drains, just like you would when we get to the duodenal injuries. You're just going to leave drains. Thoracic aortic injury, very high mortality. Those people that come to us have already selected themselves out as those people who are going to survive. They've bought some time because otherwise they would have probably died in the field, right? Again, associated injuries are very important to recognize. People rarely have isolated thoracic aortic injuries. Highest ruptures within the first 24 hours. Our vascular colleagues and our thoracic colleagues are usually involved in these cases. The latest evidence shows that the longer you can wait, the better outcomes, kind of like the pancreatic debridement patients for necrotizing pancreatitis, right? You know that the longer you wait, the better the outcomes. I think that's probably that if the patient is hemodynamically stable, they've selected themselves out as survivors anyway, so the longer you're allowed to wait, they probably are going to have better outcomes. Okay, Society of Vascular Surgery, right, rates what these injuries are. It goes from interval disruptions to aortic hematomas to frank transections. All right, CT chest, once again, non-invasive. Non-invasive is a recommended diagnostic study. So CT chest, multi-detector, endovascular repair is favored now. Many centers across the country have great experience endovascularly. Delayed repair suggests decreased renal failure, paraplegia, all the bad things that we associate with thoracic or really aortic, abdominal aortic repairs. The caveat is that most patients with delayed repairs had other significant life-threatening injuries already. And so when you, and I don't know how many of you guys have taken care of a patient with a blunt thoracic aortic injury. The bottom line is that the vascular surgeons or thoracic surgeons, depending on who's taking care of it, have very strict guidelines. The systolic blood pressure has to be this, and we don't want the heart rate to go above this. And so in your patient who have multi-trauma likely associated with this, that becomes a rate limiting factor for how close you manage. And if you can't meet all their guidelines, then that might be an indication that they need to do the endovascular repair sooner than rather than later. Because once again, you may have a competing thing going on, right? You may have TBI that's not amenable to keeping the blood pressure at a certain rate. You may have a spleen laceration that you're trying to that you're trying to manage non-operatively. So if you have competing interests, probably better just to get it out of the way. We keep systolic blood pressure generally normal. We try to decrease the heart rate using beta selective, like a esmolol drip, if necessary, and that's because of the shearing forces. Very same concept about patients who already have aortic dissections, right? Okay. Grade 1 and 2, those are the intimal disruptions, are very amenable to medical management alone. They need follow-up. They need follow-up studies. If you have a medical managed patients, just like the blunt cerebral vascular patients, we're looking for repeat of the CT angio. All right, I think we're almost there. I think I'm ahead of schedule here. But this is a classic transmediastinal gunshot wound, right? It's a classic scenario, and it's classic for tests because, well, it's so much stuff going on, and anything can be possible in terms of an injury. Okay, so let's say that you have a 26-year-old who sustained transmediastinal gunshot wound, left chest single hole, right? Just one hole on the left side that you can see. Patient is hypotensive, is tachycardic, and a GCS of 7. Your required procedures are, well, potentially all of those things, okay? Because a transmediastinal gunshot wound is just that dirty player. That bullet goes through one side, and you're going, well, it went to the left side, bounces around, can go into the abdomen. We've had patients who had pelvic injuries from transmediastinal gunshot wounds. Don't know how that happens, but you just don't know the trajectory of that bullet. Okay. If the patient's hypotensive, this patient does what? Gets this is not in the question form, but this patient needs a thoracotomy, all right? Okay. Now, do we want to do the thoracotomy in the emergency department? No. So get the thoracic surgeons, or if you're at a center where the trauma surgeons do this, take the patient to the operating room and do a thoracotomy. Okay. Chest tube is not a bad idea, and if a chest tube was on there along with thoracotomy, I would probably pick chest tube just to make sure that you do have bleeding, because clearly if the chest tube comes out and there's no blood, then the bleeding is probably in the abdomen, and you don't want to be doing a thoracotomy for that, right? But if chest tube is not on there and you have thoracotomy and laparotomy, I would do thoracotomy because you got to go where the money is, which is likely to be in the chest. Okay. If you open up the left chest and there's no blood, go to the right side, okay? Not in an ED thoracotomy fashion, put a chest tube in, all right? So put a chest tube in, and just to make sure that there's any blood in the right side, okay? Otherwise, you got to go in the belly, because that's probably where your injury is. I wanted to go over some general test taking pointers, but mostly important as it pertains to trauma. Any hemodynamically unstable patient requires intervention. They do not go to the CAT scanner. They don't go to MRI. They need some sort of a surgical intervention. Okay, no further studies should be obtained. There is a caveat to that for pelvic fracture patients who may end up in the angio suite. We'll get that into the second module of second hour of trauma for lower body injuries. If a patient deteriorates during your evaluation, you got to repeat your ABC. So go back to the airway again if it's an option. Okay. So the question prompt is that you did your A, B, and C's. As you're doing your secondary survey, the patient decompensates, becomes hypotensive again. So that patient becomes hypotensive, and you're saying to yourself on the exam, you're really, really tempted to do an E-fast, because that's what I'm tempted to do, right? I'm going to think, boy, did I miss an intra-abdominal bleed, right? Because we keep thinking, well, it's always bleeding. But the management decision at that point is not to go to the E-fast because you have circulatory collapse. It's to do what? Go back to A, to airway, okay? So somewhere along that list of options should say reassess airway, all right? Hemorrhage control is priority number 1 in sequence of operative intervention, okay? So you have, you have a femur fracture, you have a subdural, you have a esophageal perforation, and you have blood in the abdomen, right? None of those other things matter at that moment. They eventually will matter, but none of those other things matter at that time. All you care about is getting into the belly and stopping the bleeding in the belly, all right? When there are competing goals of management, and there will be more examples of this as we go through questions for the next module. So my example there is very classic. You got a traumatic brain injury patient. You got a widened mediastinum, subsequently diagnosed as a descending thoracic injury. You have a large liver hematoma and a high risk of DVT, or you have a decision. The decision then, when you have to pick these things, depends on what is the highest risk of poor outcome, and then you got to fix that first, right? So that patient with a TBI and a descending thoracic injury, which we sort of talked about a little bit, you really have to figure out, well, if the thoracic management for the thoracic injury is going to hurt the management of the TBI, then maybe we shouldn't be delaying the repair of the thoracic injury. So on the clinical scenarios, take a look at if you have lots of competing injuries, pick the one that's most likely to kill the patient. Got to address that first. I think that's it. Any questions? Yeah. Oh, this one. Okay, let's see. So the question from the audience is this question about the definitive indications for CT angio to evaluate for blunt cerebral vascular injury include all of the following except. Oh, I see what you're saying. So your point is a good one. If the question was to say, first of all, you guys know there are no except questions, right? So it's always positively worded questions. So nobody's going to ask you all of this except something. So right off the bat, this was just for sort of giving you, there are 4 points that I wanted you to remember. But the expanding traumatic neck hematoma patient should get an operative exploration, and that's fine, but they should also get a formal evaluation of their vascular system, and whether or not you explore their neck, that segment in zone 2 that you see, is not the only place that the potential injury can happen. Does that make sense? Absolutely, absolutely. So if this questions were worded as what's the next step of management, then if the scenario said that the patient had an expanding traumatic neck hematoma, the next step of management would be definitely neck exploration. The teaching point to take away from that is that the A through D are hard signs of injury, versus E, the transverse process fracture, is of no significance. But you're correct in that if you do see an expanding traumatic neck hematoma, then you should explore the neck. Any other questions? Yeah. Yeah. Oh, sorry, I misheard your question. So the comment is that there are some limitations to the accuracy of EFAST, and the gentleman was saying that if you have significant subcutaneous emphysema, and actually we talk about in the second module, obesity, there are lots of things that limit the utility of the EFAST. So yeah, there's definitely still a role for DPL, absolutely. Yeah. Right. It's the thoracic injuries, the widened mediastinum and the thoracic injury. Like I was saying, how these patients selected themselves as patients who didn't die in the field. The priority in those patients is still abdominal hemorrhage. Frankly, there's few instances where I can think of where the abdominal hemorrhage doesn't trump everything else that happens, including femur fractures that are bleeding. Because femur fracture bleedings, worst case, we just tie it up, we just put a tourniquet around it or some whole pressure. Yeah. But I would never jump to try to do anything with thoracic injuries. And in fact, if you don't control intra-abdominal hemorrhage, everything else in terms of perfusion is decreased, including patients with traumatic brain injury. Yeah. Yeah. Anything else? All right. See you in a bit.